A very good morning to the respected judges and their fellow colleagues. I'm Dr. Naqsham from GMC Srinagar, and the topic of my presentation today is management of acute corneal hydrops with compression sutures and using desmetopexy. Acute corneal hydrops is a rare but sight-threatening complication of corneal ectasias. It occurs when the aqueous humor enters the corneal stroma through a spontaneous break in the DM and causes localized stromal and epithelial edema. It typically presents as an acute decrease in visual acuity along with pain and photophobia. Rupture of DM has been reported in association with keratoglobus, keratoconus, congenital glaucoma, intraocular surgeries, Tyrrhen's marginal degeneration, acanthamoeba keratitis, and rarely spontaneously. Corneal edema typically clears within 3 months, but it can lead to posterior stromal scarring. Occasionally, stromal clefts can be seen in association with hydrops. These clefts usually close, but may result in corneal vascularization. Descemet's membrane rupture and detachments have traditionally been managed conservatively with a cycloplegic agent and topical steroid. Recently, studies have described newer surgical interventions like full thickness or pre-desmetic sutures, desmetopexy, thermokeratoplasty, and plasma injection that aim to close the posterior stromal break. With this case presentation, we aim to discern the results of using compression sutures with desmetopexy in a patient with acute corneal hydrops due to keratoconus. This is a short video intra-op video that I have put of the case. First of all, we localize the break and we pass the suture through it. 10-0 nylon is normally used. Then we buried the sutures. We use air. In this case, we used air for desmetopexy. The burying of the corneal sutures was done. And a BCL was put on at the end. This is the pre-operative picture. On the right side, we have the pre-operative picture of the patient, and on the left side, we have the first post-operative day following compression sutures with desmetopexy in the patient. This is the anterior segment OCT of the when it was a pre-operative case. And this is the post-operative picture of the same patient. We can see the BCL, the tear film, and the suture marks are also seen here. There's marked reduction in the thickness as well as in the presence of stromal edema. This was an 11-year-old boy. His name was Yasser. He had.
You have to summarize. Your time is up.
Okay, sir. He had. It was present in the right eye, and there was a marked reduction in the post-operative when we saw the patient post-operatively. What was unusual about my case that. We saw markedly reduction in the corneal thickness even on the first post-operative day, which is unusual. That's it, sir. Thank you.
Thank you. Any comment from the judges? You said it was a bilateral hydrops, right?
Sir, it was not at the same time. So there was
okay.
We had done the left eye.
So once there is a hydrops in one eye, any process you should do in the other eye?
Hydrops, so we can put the patient on.
So always consider for CXL, right? Yes, CXL can reduce, although data is not there, but it can still help you in reducing the occurrence of corneal hydrops in the other eye.
Okay, sir.
No, sir, actually, AIOS prior to surgery will tell you where the cleft is and what should be the orientation of your suturing. Okay, and then the sutures that you put, they should be thrown through continually, so that you are going to close the cleft. Then you can put the air or C3F8 or whatever.
Okay, sir.
So
Okay, sir.
Have you heard of a technique, intrastromal fluid drainage for hydrops?
Sir, I read it in one of your papers, but
go back and study. That is from our center. That is my paper basically.
Yes.
Okay, that is also a technique you can do in recalcitrant hydrops. Okay.